So I usually begin my case evaluation one up. I usually start with my axials. While you're scrolling and looking, I'll give you the history: chronic anteromedial knee pain, history of meniscal surgery in 1994. I'm always interested in the age. The patient is 65. So I'm looking at the shape of the patella. I'm looking for deep ulcers. I'm not particularly concerned in a 65-year-old about patellofemoral chondromalacia. As I mentioned, I inspect the lateral retinaculum, the plica, the MPFL, the superficial retinaculum, the medial retinaculum. This is also part of the medial retinaculum, which forms the superficial layer of the MCL. I'll look at how the patella fits into the femur. I'm going to start out nice and slow. How many osteophytes do I have? How's my anterior cruciate ligament looking? Pretty good on the femoral end. How's my PCL looking? Pretty good. How's my tibial collateral? Pretty good. How's my posterolateral corner? Not very edematous. How's my capsule? A little distended. Is there capsular prolapse? No. How's my neurovascular bundle? Terrific. How is my perineal nerve? Looks fine. There's my tibial nerve. There's my perineal nerve. How are my muscles? Not so good. Got some fat in those muscles. Patient has a minor case of biscuit poisoning. That's relevant because patients with biscuit poisoning have a high incidence of anterolateral patellofemoral impingement syndrome. They get other issues that are unique. All right, so now I go to my coronal. And if I'm practicing by myself in the office, I'm looking at all my coronals at the same time. I'm scrolling, I'm rolling, I'm wheeling, I'm dealing. And I'm looking at the shape and conformity and relationship of the femur to the tibia. Are they aligned? Pretty well. Is the joint space narrowed? Yeah, it is. And that joint space narrowing includes generalized chondral loss, especially on the femoral side. Both sides, medial and lateral. It's weight bearing. So I might say that the patient has medial and lateral, generalized, grade 2 to 3, the all-purpose grade, chondromalacia. Can't see grade 1 very well. Because it's greater than 50% depth, it's grade 3. It doesn't penetrate the bone, so it's not grade 4. So 2 to 3, the all-purpose grade. I'm not pulling out each individual erosion. I'm going to say there's minor femorotibial malalignment or shift. There are mild osteophytes. So there's mild OA. I see the tibial end of the anterior cruciate ligament. I see my posterior cruciate ligament. Let me mag out a little bit. And I've got my superficial bundle of the MCL, middle layer of the MCL, deep layer of the MCL, which, by the way, doesn't look so good. The coronary ligaments are irregular. The meniscofemoral ligament is a little floppy. The posterior oblique ligament coming from the back of the knee right there is intact. So what about my poor little squiggly meniscus? It was resected. And when you resect the meniscus, you lose the tether. You lose some of the anchors. And that's what's happened here. Now here is another concept that's very important. You take a meniscus tear and you chop it. The surgeon comes in and they chop it because it's symptomatic. And they chop it and they chop it and they chop it and they say, you know what? Now the meniscus is starting to get kind of vascular. I think I'll stop, even though there's some signal remaining in the meniscus. So everybody that has flap tears and cleavage tears that get approached surgically will have residual signal in this remnant, and I don't care. And now that signal is freely communicating with an edge that got chopped. That's called meniscal conversion signal. And if you do arthrograms on those, you are making the contrast person rich, and you're wasting your time. I have not done an MR knee arthrogram for this purpose in 10 years. If this is a symptomatic remnant, then it is going to be extruded, flipped, twisted. It'll have a cyst. It'll be inflamed. It'll be gapped. But it won't have a simple linear or oblique signal that is symptomatic or needs to be addressed. Because 95% of the time, people that get meniscectomies that have symptoms, it's related to this, chondromalacia. Now let's scroll some more. Now what is happening to our meniscus? It is starting to extrude into the paratibial gutter. And what's all this around it? Swelling. So is it contributing to symptoms? Probably, but what are you going to do about it? If there's locking, probably remove it. If there's no locking, then probably sit on it. In younger people, when you have highly functioning, busy, athletic individuals, they will go in and remove these when they start to go down into the paratibial gutter. So this subtle gutter extension could be relevant in a younger person. You generally never want to go in and take out the outer third of the meniscus. So if you took this out, you never want to go in and take that out, because now you get a total knee when you're 32 years old. So I am very liberal about signals in the outer third. I'm very generous in my discussion about, or very conservative in my discussion about how I handle tears in this location. Let's keep going, shall we? Because there's more. We have a T1 weighted image on the far right, the spin echo, which doesn't show much. And on the far left, we've got something that is still there, but bigger and blacker and badder. And maybe there's two of them. That's blooming. Gradient echo on the left, spin echo on the right. This time we're blooming a body. How do we know? Because on the T1, it has a corticated edge. Let's blow it up even bigger. You can too. It's got a corticated edge. It's got a shape to it. And the one above it, really hard to see, but easy to see on the gradient echo. So gradient echo, articular, especially powerful gradient echo like adage, MFFE, merge or medic. Let's demagnify the coronal. We have other things to look at. This is our first case, so we're going to approach it kind of quietly to begin with. We've got our fibular collateral ligament. We've got our biceps femoris, which has a two-headed insertion. They do come together, but they actually have separate footprints on the fibula. What else do we have? The oblique fibular ligament, the so-called Sagun ligament, that'll tear off a piece of bone when there is a lateral capsular rupture. We've got the popliteus hiatus, which is fun-loving because it loves gout. Fat popliteus hiatus in a man, you got gout. What else do we have? The tib-fib articulation. In the axial projection, you've got tib-fib ligaments. The arcuate ligaments are a little hard to see. Perhaps we see one of them, the medial bundle of the arcuate right here. The patient does not have a fibella, so does not have a fibular-fibellar ligament. Let's go to the sagittal. We have one sagittal. It's a fat-suppressed, proton density, spur. So it's our detection sequence. We're looking for swelling because there's so much going on here. The patient has anteromedial pain. The body was posteromedial. Should we take it out? Probably not. Patient 67, that's not where the pain is. It looks like that body has been there since the Jurassic period, a long time. So where is all the swelling? All the swelling is over here. It's a bone scan without an injection. You're looking for the hot spots. It's that simple. Yes, there's chondromalacia. Yes, there's an effusion. Yes, there is a body. But the thing that is producing the patient's pain in this case is the meniscectomized area that has allowed the meniscus to become an unstable remnant, wiggling around, going into the gutter, creating capsulitis, and therefore the therapy will have to be directed there. Shall we do another? And by the way, my sagittal gives me a beautiful view of the PCL, the mid portion of the ACL and the anterior and posterior menisci laterally, medially as well, although as we get out peripherally, we see where the pathology exists. So for antero and posterior meniscal tears, the sagittal. For body tears, you're going to go with the coronal, and just about every adult is going to have a horizontal cleavage body tear after age 60. So don't get too excited about those unless you have a cyst or inflammatory reaction. The inflammatory reaction, as in this example, is critical to the correct answer. Because in every knee, there are 20 findings. And if you just sit there and rifle off 1 through 20, they will hate you. Next. Posterior pain with deep flexion and rotation. Evaluate for posterior horn meniscus tear, Baker cyst, posterior capsular sprain, or other. In other words, rule out life itself. Please solve this problem for me. The patient complains of pain and stiffness since 9/16, so it's been about 2 months. The patient is unsure of their surgical history. How can you be unsure if somebody has done surgery on you? I don't get that. By the way, many people do not think arthroscopy is surgery. So if you see somebody that has an arthroscopy tract and they say they've never had surgery, that's probably the case. They don't consider that major surgery, and they usually answer no on their take-in sheet. All right, so I've got my axial up. I'm noticing the proliferative bone in the anterior patella, which is known as the tooth sign of Keats. It's a sign of enthesopathy and rubbing of the prepatellar plate, often asymptomatic, but occasionally associated with delamination tears of the prepatellar plate. This patient has an asymptomatic delamination type tear of the prepatellar plate. That's not his problem. Nor is this small fissure in the trochlea. That's called living. We have a gorgeous MPFL. We have a nice thick but asymptomatic plica. We have a superficial medial retinaculum, which becomes layer number 1. The MPFL becomes layer number 2. We've got our ACL, femoral end. It's a beauty. We've got our PCL. We've got our TCL. We have our oblique popliteal ligament. We have our direct head of our semimembranosus corner, which contributes to the oblique popliteal ligament. So does the lateral corner, contributes to the oblique popliteal ligament. It gets complex. We've got the neurovascular bundle. It's great. Okay, let's move to something a little more interesting. There's more in our search pattern axial, and we'll hit them again and again as we move forward. Let's go coronal. In the blue boxing trunks on the left is our gradient echo. This is an additive gradient echo. In the red boxing trunks on the right is our T1 spin echo. Articular, anatomy. Let's scroll. Now there are 20 things wrong with this knee, right? The knee's swollen. I already showed you a small fissure. I already showed you a prepatellar plate abnormality. All of that's going in the body where other radiologists can see it. So they can't say, that's Steve, he missed that thing. I don't want the clinician to see all that. I don't want to bog them down. But when they ask me, well, what about this thing I saw? Look in the body. I want in the conclusion what the clinician is asking for, what they need to know, what they need to do to the patient. And the clinician will love you for it. So there is femoral shift relative to the tibia. They're not aligned. There is some osteoarthritis. If we flatten it out, there is loss of cartilage. Look at that tibial cartilage. Way too thin. Let's blow it up. Look at all that chondromalacia. It's a 3 millimeter cut. So yes, there's generalized chondromalacia. Is that contributing to the patient's symptoms? You bet it is. Because the patient has medial pain. And I have most of my swelling in the medial axis of the knee. Yes, there is some signal, some closed signal in the lateral meniscus. We said everybody over the age of 60 is going to have some cleavage signal in the lateral meniscus. In fact, in both menisci. That signal is horizontal. It's not very bright. It may be trizonal. It may communicate in the free edge. It may be closed. If it communicates, I'll call it a chronic cleavage tear, incidentally noted, in the meniscus body commensurate with age. If it's not communicating, I'll say there's closed cleavage signal commensurate with age. End. Goes in the body, nowhere else. Done. Don't forget to look for central chondromalacia, which this patient has. We won't dwell on it right now. But they have extensive medial weight-bearing diffuse class 3 chondromalacia. Does it penetrate bone? Does it penetrate the subchondral plate or cortex? No. Is the medial compartment remodeled? Yes. It's not curved, it's flat. That's a problem. That's not how it was made. What about the meniscus? The patient is not even standing up. Look where the meniscus is. The meniscus is extruded. It's not anchored. It's not tethered. So when they stand up, it squishes out like a piece of toothpaste from the tube. It's meniscal failure. Meniscus is no longer a functioning structure, and it has a thick, much thicker than the other side, a thick, complex pattern of flap tear associated with it. So how might I describe this? Medial compartment failure with medial femorotibial shift, diffuse class 2 to 3 chondromalacia punctuated by meniscal failure. The meniscal failure is greater than the chondral failure. Punctuated by meniscal failure with a large 3 to 4 centimeter complex flap tear and meniscal extrusion. That would be my conclusion. Now let's see if there's anything else we could pick off in the sagittal. Well, there's our tear. It's kind of a little more ill-defined. It's much clearer in the coronal projection, especially the pattern of extrusion. There's more of the tear right there. Let's blow it up. There's more of the tear. Inner third signal intensity. Some fibrillation in the back. Let's keep looking. More of the tear. Oh, that's nasty right there. Yes, it's ill-defined, but it has no business being in the inner third. Meniscocapsular corner is swollen. Let's keep scrolling. ACL fine. PCL fine. Let's go to the lateral side. I will zoom out. And these signals don't bother me at all. Closed, ill-defined lateral meniscal signal, no traumatic tear. Period. Body of the report, end. Put it away. So it's all about the medial compartment in this case. And all the other nits and bits and tidbits go in the body for other radiologists to see. Shall we do another?
Number 21.
That measured out surgically as a 4 centimeter unstable flap tear.
Next, 021.
021. Is this fun or what? MRI is ridiculous. You get paid to have fun. It's like solving the New York Times crossword puzzle 50 times a day. This next patient is 23. He had an injury 1 week ago. He jumped and felt a pop. Okay, I am going to start with my axial. He wiggled a little bit. It's a T2 fast spin echo. He's got an effusion, not good for a 23-year-old. He felt a pop. He could have dislocated his patella, which means he ruptured his MPFL, or he fractured his medial facet, or he injured his anterolateral femoral condyle. Not. But that's an important cause of a pop. Another cause of a pop, meniscal rupture, yet to be determined. Another cause of a pop, ACL tear, yet to be determined. How's our femoral end? Pretty good. How's our PCL? Pretty good. How's our TCL? Pretty good. How's our posterolateral corner? Not swollen. There's our popliteus. There's our fibular collateral. Pretty good. A lot of information gleaned from just scrolling the axial. At least we know we don't have a patellofemoral dislocation. This time, I'm going to go directly to the sagittals because I've got 3 of them. And with a history of a pop, I'm worried about the cruciates. And I can get the menisci at the same time. Got a PD spur on the left, T2, spin echo on the right, T1, morphologic image in the middle. Detection, refinement. Let's go. Meniscal rupture, lateral, I don't think so. Medial, I think so. Let's look at the triangles. The triangle should be a little bigger in the back on the lateral side than the lateral meniscus triangle should be a little bigger in the back than it is in the front on the lateral side. On the medial side, the triangle should be even bigger in the back than in the front. But that is not the case. In fact, we have almost no meniscus in the back of a 23-year-old. That's not good. Where did it go? Could have been meniscectomized, but it wasn't. That should be your first thought in a 50-year-old. But not in a 23-year-old with a virgin knee and no arthroscopic tracts. It went somewhere. It went here. It went in and forward. So we can do something like this. We said we would talk about the shape of meniscal tears. Let's do it. So what happened to this meniscus, and I'm going to put up the coronal in a moment, is they split the meniscus down the middle, and then that thing became a gap. It widened. And then the meniscus did something like this. So the piece kind of started to fold forward. There's a big hole here. And this piece can twist. This piece can migrate this way in front of the native lateral meniscus. Or it can migrate inside and go underneath the meniscus and produce what's called the double anterior meniscus sign, which we do have. Right? We got 2 pieces here, 2 triangles. One is really far forward. Let's scroll. What's that? That is this piece. Whoops, apologize. We got a big hole. That is this piece of the meniscus that is now flopping in or folding into the notch of the knee. And then part of that piece has decided to migrate forward, so it looks something like this, giving you this double appearance in the front. Quick draw of some other meniscal tears. This would be a radial tear, little triangle right from the inside. When they're 8 millimeters deep, you may have to resect them. If you have a little radial tear and it decides to curve, you call it a parrot beak. If it's a big curve, you call it a flap, which is one of the more common tears. If you've got a tear that is got a nice horizontal axis, it's a cleavage tear. They can be traumatic or degenerative. If you've got a tear going this way, it's vertical. You hardly ever want to do anything to vertical tears unless they gap. If they're in the outer third, you almost never operate on them. You can also take menisci and separate them from attachments. And that will be a story for another case. So now let's continue scrolling. 2 friends, unfortunate friends, are ACL deficiency and bucket handle tears. Do we have ACL deficiency? Which was their first question. Rule out ACL tear. So do we have an ACL tear? Mid portion? Perfect. Femoral end? We already established it was fine axially, still pretty good. Tibial end off the coronal? Winner. Winner, winner, chicken dinner. The tibial end is still on. Is the ACL floppy? Is it loose? Is it lax? Is it wavy? No. Is the tibia translated forward? No. So it is not an ACL deficient knee. It is not an ACL tear. It's just a big, whopping, honking bucket handle tear. Let's go back to the coronal for a moment, because we can. We said the meniscus did something like this. It had a tear, and that tear is gapped. And that allowed the meniscus to migrate in and create a bulbous segment into the center of the knee. Now, what about the outside piece? How much is left out here? How much of this big hole has encroached on the rim? How much rim do we have? Not a lot. Surgeon wants to know that. Do they have anything to sew back to? Where's our inside piece? Right there, underneath the PCL. That's not an accessory bundle or an anterior insertion of the broad PCL footprint, a common pitfall. It's a piece of meniscus. And how do we know? Let's scroll. Let's roll. There's hardly any meniscus in the back because it got ripped off. And we come forward, and we know that there is a piece here, and it could be that we just have a curved meniscus. It could be that the meniscus is just curved like this, and we volume averaged. We know that's not true because it's on every single cut. If this were the case, maybe one cut. But look at every single cut, and we will find a piece everywhere. In the front, there, there and there, there and there, there and there. It's getting bigger. There and there, there and there, there and there. We'd like to see it come back together. Maybe you will, maybe you won't. This one did come back together eventually in a very thin posterior rim. This is the mother of all buckets. And there's an effusion. Collaterals, they're okay. Anybody have any comments? Let's go. Patient referred for a moderate, sharp, dull left knee pain for 2 weeks. Swelling, instability, locking from sitting to standing. Complains of knee pain, stiffness. It's a woman. She is born in 1994. She's 23. Axial. No patellofemoral dysplasia. I take that back. Mild patellofemoral dysplasia. Her lateral femoral ridge is a little tall. She's got a little extra tubercle along her lateral facet. MPFL, fine. Medial retinaculum, fine. Lateral retinaculum, fine. Effusion, complex. What's in it? What could be in it? Gout? I don't think so. 23-year-old woman. CPPD? Never fills a joint like that. PVNS? Not dark enough. Amyloid? Rare. Usually with blood. It's a woman. She's 23. She's got an effusion. And inside of that effusion, she's got gray material. Game over. It's RA or JIA. So she could be rheumatoid positive or rheumatoid negative. Frequently in JIA, they are rheumatoid negative, but they still have rheumatoid. Let's keep looking, shall we? What else might we like to see in this patient who is presumed to have a mechanical internal derangement? Let's go sagittal since we have more of them. And we are fast, expedient, we're efficient. We're rolling, we're scrolling. Scroll them all at the same time. What do we want to see in somebody that has an inflammatory, autodigestive, proteolytic enzyme-producing arthritis? We want to see a floppy joint, elasticity of the joint with an effusion. We've got it. We want to see autodigestion, enzymatic digestion of cartilage, thin cartilage. Let's blow up our water-weighted image. Oh, it's thin. It's a 23-year-old lady, way too thin. We want to see small menisci. Autodigestion of menisci, she's got it. They're tiny. They're not torn. They're not displaced. Let's take a look at our T2. What are we seeing inside that joint? Pannus. What are we seeing behind the joint? an inflamed reactive lymph node from RA or JRA. She does not have a mechanical derangement. Her ACL and PCL are intact. Her menisci are small, but they're intact. Let's go to the coronal. Now on the PD spur, it's not a particularly sensitive articular sequence. It's good for ligaments, it's good for bones, it's a good generalized sequence, it's a good search and destroy sequence, but the actual guts of the case are solved on the first image, the T2 weighted image, and if we had it, a gradient echo image, but the T2 weighted axial image shows the massive pannus inside this distended joint. All the other supplementary signs, small menisci, thin cartilage, elastic joint, reactive lymph nodes, and erosions, by the way, are seen in the other projections. Let's look at our corona. Look what happens to the attachments of the menisci. That's not an injury. That meniscus is extruded because the attachments are being proteolytically digested by aggressive RA, and the meniscus is no longer able to hold, even with the patient lying on their back. And that's why this knee will degenerate without early, immediate treatment. That's the value of MR. Rheumatologists now uniformly agree that early, aggressive action in patients with inflammatory arthritis is a joint-saving procedure. And the earliest method for picking up inflammatory arthritis, whether it be seronegative or seropositive, JIA, RA, psoriasis, other, AS, is MR. As you're seeing swelling first and no other mechanical derangement. When you come back, we'll talk a little bit more about JIA and arthritic conditions, and I'll have a few classification systems for you. Take a break. We'll get few other chances to cover arthritis with such alacrity and such a grotesque example of it, with tremendous pannus in this young woman, and younger individuals, especially those between the ages of, say, 12 and 25 who do have inflammatory arthritides, tend to be more seronegative. So I'd like to talk to you a little bit about arthritis for a moment, because many of you are going to get asked to stage and grade and evaluate arthritis and its progression or regression based on some of the newer immunosuppressive therapies, which are awfully effective but carry with them some potential long-term morbidity. Those of you that were here at the neuro course know that the incidence of PML, progressive multifocal leukoencephalopathy, is on the rise because of these immunomodulating therapies that are used for arthritis and for MS. So we come back to our case. One of your colleagues was asking me if there was a body in this case. There is not a body. He was referring to a big lymph node in the back. I don't mind lymph nodes at all when they're fat-filled. When they are uniformly gray, then they are abnormal. This one is uniformly gray, and this one is filled with rheumatoid granulomatous material. As we said, the patient has pannus, and I mentioned that there were erosions, or I hadn't showed them to you yet, and here is an erosion in the central aspect of the joint space. So let's talk about arthritis for a moment, because we are going to have a lot of opportunity to do so again when we get into the hand and foot. Probably the most well-known classification for JIA, which is a lot more common than we once thought and is a very important cause of knee pain when you have no major internal derangement, is systemic arthritis, where you have one or more joints preceded by 2 weeks of fevers daily for at least 3 days of at least one. And they may have a transitory rash, generalized lymphadenopathy, hepato or splenomegaly, or serositis. Then you've got oligoarthritis, which is quite common. This patient would categorize as an oligoarthritis patient, 1 to 4 joints. Diagnosis usually occurs within the first 6 months of the patient's symptoms. Polyarthritis, 5 or more joints affected, diagnosed within the first 6 months with a negative rheumatoid factor test. And ILR stands for the International League for Association of Rheumatologists. It sounds like a cricket league, a rugby league. They like to make themselves look tough, but they're really not. So we said polyarthritis, 5 or more joints in the first 6 months, or they might have 2 positive rheumatoid factor tests in at least 3 months, or separated by 3 months apart, but within 6 months of symptoms. Now, in patients with juvenile arthritis, psoriatic arthritis is considered arthritis with psoriasis, or they may not yet have psoriasis. And psoriatic arthritis is one of the most variable of all the juvenile arthritides. Unfortunately, one of my partners is afflicted with it, and he is virtually rendered incapacitated. So it can be all the way from very minor dactylitis all the way up to pure, complete systemic involvement. The classic is dactylitis with a swollen finger, nail pitting, onycholysis, and/or psoriasis in a first-degree relative would be considered part of the scale for psoriatic arthritis. Then we've got enthesis-related arthritis. Some of you know it as Reiter's syndrome, but that's just one of the subtypes. It likes to affect the attachments, and it has a strong propensity for the sacroiliac joints. They usually have a positive HLA-B27. They're usually males over the age of 6. But yes, this condition does affect juveniles, so it's in the juvenile idiopathic arthritis cavity. The juvenile idiopathic arthritis group. When they're acute, they're symptomatic. They may have anterior uveitis, and they may or may not have a history or a family history of ankylosing spondylitis. They may have the classic Reiter's syndrome presentation of uveitis and urethritis or not. If they have uveitis in a first-degree relative, that is considered a substantial risk factor for enthesopathic-related juvenile arthritis. Then you've got undifferentiated arthritis that falls into more than one different category. So JIA oligoarthritis is what you're going to encounter not uncommonly in people under the age of 25, all the way down to age 6. It's the most common type of JIA. It likes the knees and ankles, usually of preschool-age girls, so the most common presentation would be about 6 to 12 years of age. They frequently have a rhinocyclitis as a tip-off to the diagnosis, and when they're rheumatoid positive, they usually have more joints involved, and they usually have symmetric involvement. When they're rheumatoid negative, it can occur at any age. And this patient was rheumatoid negative. I see them all the way up to age 30. This patient was 23. There's not as much symmetry, and there's really no characteristic joint pattern, and this is the subtype that presents with a single swollen joint like this lady has. There is a systemic variety of JIA that is very serious, potentially lethal. It presents with fevers, rash, visceromegaly, and lymphadenopathy. They may have one or more swollen joints, but the key is the visceral involvement. Those patients have to be jumped on immediately and aggressively. So if you get somebody with a big swollen joint and a swollen abdomen or abdominal pain, you go right to MR or CT of the abdomen. And symmetry may occur late in this syndrome. There is another entity you should be familiar with called macrophage activation syndrome. So a patient presents with a swollen joint like this, and all of a sudden their white count drops. Some people incorrectly ascribe that to an acute onset of rheumatoid or an exacerbation of rheumatoid, but these patients usually have a low SED rate, not a high SED rate. They have pancytopenia, DIC, and liver dysfunction with a sustained fever, and they may go on to multi-organ failure. So you got a big joint, somebody gets a fever, they come back, they tell you the white count is 2 and the SED rate is 3. You've got to act and act fast and work with a clinician to come up with a suitable treatment course, otherwise they will die. Enthesopathic-related arthritis, usually boys over the age of 6. It likes the Achilles insertion, it likes the plantar fascia and the tarsal bones. It's frequently an asymmetric arthritis. It likes the hip, and it also likes the SI joints. The spine is usually not involved until adulthood, so you shouldn't really run into too much trouble confusing this with classic ankylosing spondylitis, which starts in the sacrum or has sacral involvement with some frequency. Juvenile psoriatic arthritis, as I mentioned, is a weird entity. It can involve large or small joints. It can be minor or terribly severe. Dactylitis, involvement of fingers, often does precede skin changes, so you may not have a history of psoriasis to defend you or help you. A couple of pearls regarding JIA. The prevalence of erosions in joint space loss is higher in children with polyarticular JIA than oligoarticular. So if you've got more than 3 or 4 joints involved, 5 joints, then they usually will have more erosive disease and a more grave prognosis. Periostitis is more common in JIA than adult onset RA. And this periostitis may give the bone a very thick appearance on plain film, so the bone almost looks squared off. It resembles, calcific deposition that can be seen in hydroxyapatite deposition disease or HAD. On MR, edema always precedes erosions. MR is the earliest detector of an inflammatory arthritis, bar none, including nuclear scintigraphy. And we want to get them early. There's no radiation, so this is a test that has come into its own. It should replace scintigraphy for evaluation. It should absolutely be done in lieu of conventional radiography for early detection. Of course, you can follow the patients in a cost-effective fashion by using radiography, but radiography is very insensitive. It only shows erosions, and if you want to see the changes in pannus, the changes in inflammation, you can turn your attention to MR of small or large joints, and I refer you to the clinical OMERAC trials, which you can get on the internet, describing the degree of synovitis, pannus, edema, erosions, and we do this in the wrist and hand all the time for our rheumatologists, many of whom have their own magnets in-house. There's also a RAMRIS scoring plan or axis, and it's done in 2 axes, the short axis and the long axis, and that is also online. Rice bodies. You're going to encounter these quite a bit in inflammatory arthritis. This is proliferative pannus that undergoes fibrinoid necrosis and sloughs into the joint. So they look like rice. They're very small, they're gray, they're not going to be as black or as big as synovial metaplastic bodies or PVNS. Some people use contrast MRI to look for inflammation. If there's inflammation with gadolinium, it is said this is a sign of irreversible cartilage loss. I personally do not like to give gadolinium to children with small fields of view and good stir imaging. I can do all the things I need to do without giving contrast, so personally, I do not give contrast for grading or staging OMERAC system or otherwise for JIA or any other arthritis. The spoke wheel pattern of enhancement has been described as evidence of hyperemia and cartilage destruction. Again, I don't use it. Cervical region. This is more commonly involved in children with polyarticular or systemic JRA than oligo. Our patient is an oligo, and they classically get ankylosis of the apophyseal joints. For some ungodly reason, it likes C2-3, and the bodies may become hypoplastic in the anteroposterior and transverse dimension, and so they get what's known as a juvenile cervical vertebra. The TMJ may be involved in oligoarthritis in JIA. Usually presents at an early age, and if patients have a JIA presentation before age 4, they invariably will get TMJ arthritis later on in life. The SIJ, the sacroiliac joints, the enthesopathic variant involves the sacroiliac joints in 30%, but in ankylosing spondylitis, it's involved at presentation in 90%. It's important, though, to recognize when it is involved because some drugs do not work in JIA if the sacroiliac joint is involved. So the clinician will pick their drug based on presence or absence of sacroiliac joint involvement, so it's quite a bit more complicated than you otherwise might expect. Let's move on to our next case now. Patient had a motorcycle accident and now has pain. He's 24 years old. I'm going to start with my axial, but I'll give you moments to digest. Now, some of you might be saying to yourself, my goodness, what do I do with a case like this? My routine would be to go to the axial and yes, I've been doing this a long time, since the Cretaceous period. So I could look at this axial and say the ACL is gone, the PCL is gone, the posterolateral corner is gone, there's a medial injury, there's been no patellar dislocation, but there probably has been a knee dislocation. And I would come to that assumption that quickly. But not all of you are masters, but you will be, because you have passion and you're here. So let's pull out the water detection sequence, the sort of search and destroy sequence, and we have two of them. We have a coronal and a sagittal, thank goodness. But on the flip side, there's swelling, there's edema, there's morphologic disruption everywhere. So what's a mother to do? What I would do is try and figure out the mechanism of injury. Is it a blast? Is it a pivot shift? Is it a hyperflexion? Is it a hyperextension? Is it varus? Is it valgus? And I have decided pretty quickly that it's hyperextension. Remember we said that kissing lesions, anterior, between the femur and the tibia, there's another small kissing lesion adjacent to the anterior femoral condyle insult, means that you hyperextended. Hyperextension usually is a prelude to knee dislocation. So when you see multiligamentous disease with this bone pattern and the menisci are spared, it's a knee dislocation proven otherwise. Now once you know it's a knee dislocation and you've already established very quickly that the meniscal tissues themselves, not the meniscocapsular attachments, but the meniscal tissues themselves are intact, now it's all about the ligaments and capsule and which ones are injured. So we're pretty much done with the skeleton. Yes, I will give you the fibrous inclusion defect or non-ossifying fibroma down low, so what? That goes in the body of the report. I will start my conclusion with kissing bone lesions anterior, consistent with hyperextension, dislocation mechanism of injury with the following ligaments disrupted, and then I'll go medial, 1, 2, 3, 4, 5, or A, B, C, D, E, and then lateral, A, B, C, D, E. And then at the bottom I'll put menisci spared. So let's take the ligaments on now, one by one. I'm going to go back to my axial just for a moment, because this is how I would normally look at a case. And I have digested that the posterolateral corner is full of blood. I've detected blood filling the ACL sheath, the PCL sheath, and some blood in the posteromedial corner, although not as much, and some dissecting anteromedial. So I'm worried about both corners, both cruciates. The patient did not, fortunately, fracture or dislocate their patella, but there are much bigger fish to fry. Okay, so let's put up our coronal first. We can get a lot of information here quickly. We again reaffirm the integrity of our menisci, but what about our meniscocapsular attachments? The attachments laterally, not so good. Now they're easier to see posterior, but there should be some band attaching the lateral meniscus to the femur and one to the tibia. Those are gone. On the medial side, let's blow it up a little bit. The one going down, the coronary ligament's intact. The one going up, it's blunted. And it merges proximally with this structure right here, which is called the POL, the posterior oblique ligament, also known as the ligament of Winslow. All right, let's look on the lateral side now. On the lateral side, we've got a ruptured fibular collateral ligament, a ruptured popliteus tendon. We have ruptured the capsule. We have a Sagun sign. It's subtle, but there it is. A piece of cortex, a little flake of cortex is off. There's a little edema here, and the oblique ligament is off. So we've got a lateral capsular rupture. How about the anterior cruciate? It's gone. How about the posterior cruciate? It's gone. How about the meniscal root ligaments? They're present. There's one, there's the other. Let's keep going, shall we? Let's take on our posterolateral corner first. So here is our popliteus tendon and our popliteofibular ligament. Well, that one's intact. That's probably the only one that's intact. But the reason it's intact is the rest of the popliteus is ruptured. So we already said the popliteus tendon is torn up higher. What else is in the posterolateral corner? The arcuate. It's shaped like a V or a Y. There's a medial and lateral limb. There is a vestige of it right there. I'm going to make it a little bigger for you. It's completely ruptured. It's macerated. That's one of the limbs. That's going to be the lateral limb. The medial limb is probably not visible. Let's keep looking, shall we? What else has been injured in the posterolateral corner? Well, the popliteotibial attachment, intact. But the menisco-popliteal fascicles that anchor the lateral meniscus to the back of the knee, they're gone. There's an upper set and a lower set. They're broken down into medial and lateral upper sets and medial and lateral lower sets. There's one of the ligaments barely present and a little squiggly. The upper ligament is gone. So meniscocapsular detachment. What about the posterior capsule and oblique popliteal ligament, the OPL, which, by the way, goes all the way across the back and connects to the posteromedial corner? That should be a nice, thick black band. It is gone. There's a little bit of it right there. You can see it's ruptured here. So the posterior capsule is ruptured. Let's go over to the medial side, where things are not quite as dicey. But they're not quite so good either. So there is a block-stop mechanism that keeps the posteromedial meniscus stable. So when you flex your knee, it keeps the meniscus from rocking back and forth. And what does that is the semimembranosus tendon. So here is the main tendon insertion, the direct head insertion, and that inserts on a little tubercle of the tibia. You can see it's a little fat and a little swollen. And then later on, I'll show you in some greater detail some of the other aspects of the posteromedial corner, including the distal bundle of the posteromedial corner. This one is known as the pars reflexa, or anterior portion of the posteromedial corner, all part of the semimembranosus mechanism. But there is another abnormality here that's part of the posteromedial corner, and that is this. That's the meniscocapsular attachment, and that is injured. You should have a discrete little band of low signal here with a clean little fat pad behind here and a little bit of capsulosynovial tissue, but not this globular gray area, which is blood that has now filled the meniscocapsular junction. And look at the main semimembranosus. It's swollen and injured. Here is the distal bundle, by the way, of the semimembranosus attachment. There are 5 major components of the posteromedial corner, and there are also 4 or 5 subsegment slips or attachments of the semimembranosus, and we will cover those. But this is just a quick look at it. For those of you that are at the more novice stage or intermediate stage, the most important thing is for you to recognize that the semimembranosus itself is not detached, but the posteromedial meniscocapsular reflection is injured. Now, we said there are 5 components of the posteromedial corner, and I didn't intend to describe all of them, but there is one other one I want to point out to you. I said that the posterior oblique ligament, the oblique posterior ligament, the OPL, which goes all the way across the back of the knee, from the lateral side to the medial side. Let's go to the lateral side. It's ruptured. Now keep going. Ruptured, ruptured, ruptured. Let's keep going. Still ruptured. Still ruptured, and we're in the posteromedial corner. That is the OPL of the medial side. So the OPL on the medial side is gone, the OPL on the lateral side is gone, and everything in between is gone. So there's a posteromedial corner injury and a massive posterolateral corner injury. An ACL, a PCL, and we can describe the individual subsegments of each corner that are gone. So once again, let's go to the conclusion. Conclusion. Hyperextension dislocation injury with meniscal sparing involving the following. 1, ACL rupture. 2, PCL rupture. 3, posteromedial corner injury involving the OPL and meniscocapsular attachment. Number next, posterolateral corner injury rupturing the meniscofascicular attachments. A. B. Popliteus tendon. C. Posterolateral capsule. D. D. Fibular collateral ligament, and so on down the line. And that would be my conclusion. A rather extensive conclusion, longer than I usually would give it. But those are all relevant to the management of this patient. I would put the non-ossifying fibroma in the body of the report. Are there any questions about this case? It's a rather dramatic one. Pretty good look at the direct head insertion of the semimembranosus, which is intact. Let's move on. Okay, this is a patient that had a fall in December of 2015, December 2nd, so 6 days earlier. Patient is 54, I believe. Nope, got that wrong. 44. It's a woman. I'll start out with my axial. This came off of a 1.5 Tesla Hitachi oval. You are looking at an axial fast spin echo T2, 3D. So I can, if I want to, reconstruct these in any orientation. They are 50% overlapped, so they're high resolution. And I've got some excellent looking hyaline cartilage of the patella. Nice trochlear cartilage. Patient is not dislocated. The MPFL is intact. The length of the medial and lateral facet is normal. It's got a good looking apex. Nothing's displaced. I have a swollen knee. I have a fusion. And I am looking at the tibial collateral ligament. I've got one. I am looking at the posterolateral corner. There's swelling superficial to it, but not in it. The PCL, normal. The ACL, not so much. The ACL is diffusely swollen. So even though I have not even gone to any other projection, I've already established in my mind that there is a high-grade to full-thickness ACL tear with the PCL intact and no major collateral injury. Now, if I wanted to, I could reconstruct this and interpret the entire case from this one image in an 8-minute acquisition and a 3-minute dictation. And I would have 10 minutes and I'd be done. Now, why don't I do that? The clinician wants to see more. But as the pressure rises economically throughout the world, and especially on radiologists, that is what's going to happen. But that's a story for another day. Okay, let's 3-up the rest of the images now. Hit number 3. Put up your sagittal, your 2 coronals. So on the far left, my left, and your left, is a fracture. Now this is a macro fracture. If you blow it up, you can actually see that the line is jagged. You might say, well, why don't I see the line as well? Because there's edema on the inside fragment and edema around the outside. So it obscures the thickness and nature of the fracture. So you might have to go to another sequence, like this water-weighted sequence, and now you see the jagged nature of the fracture and the cortical step-off, which makes it a macro fracture. What else makes it a macro fracture? It's depressed. So it's displaced. It's gapped very slightly at the cortex. So now that we know we have a fracture here, let's check out the corner. A stretched but intact popliteofibular ligament, a swollen arcuate recess, and a torn menisco-popliteal fascicle. The inferior fascicle adjacent to the fracture got pinched. There should be a fascicle here, like that one. It's missing. Well, okay, we have bigger fish to fry. Look at the position of the tibia relative to the femur. Drop a line. Look where the tibia is. It's anterior to my line. That could happen on one side, but not on both sides. If it happens on both sides, you've got anterior passive tibial translation. You've got ACL deficiency. So even if the ACL isn't torn, it's still deficient. But it's torn. It's torn right there. You can see it torn in the coronal projection, filled with blood. And you can see it torn on our coronal gradient echo adage, filled with blood. How about the menisci? Now, there are certain things you need to know about interpreting menisci. Besides just, it's horizontal, it's vertical, it's oblique, it's complex. And I use the word complex, by the way, when I want to go fishing. Like if I have a flap tear and I have a few other little tidbits of signal moving in other directions, I don't describe all those other little signals. I just say complex flap tear. I'm done. Because complex can mean anything. And I go have a cup of coffee. So you got to know when to hold them and when to fold them. But what do I mean by meniscal evaluation and other factors? For instance, age. Age is going to determine how I describe the meniscal signal. The surrounding tissues. If the surrounding tissues are bounced, if they're contused, I'm more likely to call the meniscus traumatic or contused or a tear. If I have signal in the outer third of a 10-year-old and there's posteromedial pain, you know what? If that signal is not discrete and razor-like and bright and associated with swelling, I never call it a tear. Never. Because even if it is a tear, I don't want it resected. And it usually isn't a tear. It's usually vascularity. If I've got a serious injury like this, and this patient's middle-aged, she's actually 54, got the age wrong. Okay, I'm going to expect, as we described in our initial lead-in to MSK, I'm going to expect to have some signal inside the menisci. So I now decide, is that meniscus signal closed or open? In other words, is it open to the articular surface? Well, certainly on the medial side, it goes into the inner third. On the lateral side, not so much. Let's blow it up. Are we going to go in and do a meniscectomy in a 54-year-old lady for this? Never. Never. So we have to use terms that properly sequester this signal for the clinician and for other radiologists. So a horizontal cleavage-type signal in the medial meniscus body, chronic and likely incidental. Closed signal, likely degenerative in the lateral meniscus body. Boom, I leave it in the body. Doesn't go in the conclusion. Now, could there be a contusion here because there's a fracture? Sure. I might toss that in there. But I'm not going to give it an unstable, traumatic, actively inflamed tear, which means go get it. So we have a fracture. We have an ACL tear, PCL intact, collaterals intact, no meniscocapsular separation, meniscal ligaments are intact, and we'll describe our fracture in the conclusion as a minimally depressed, less than 1 to 2 millimeters depressed lateral tibial edge macro fracture. That's number one. Number two, ACL transection. Number three, no unstable traumatic meniscus tear. The rest of the meniscal discussion goes in the body of the report. Now, one other aspect of meniscal assessment that you must train yourself to do, and one of the beauties of ProScan is we read every single scanner in the world, every subtype, every vendor, every field strength. And we know which sequences make the menisci too bright, which sequences make them too dark. But for you, you'll have your own equipment. Learn when the sequence is an over-describer and learn when the sequence is an under-describer. Most T2s under-describe meniscus pathology. Some gradient echoes, especially thin ones, will over-describe and over-show meniscal signal or make it so conspicuous that you will read a tear in virtually every case. This is one of them. But the beauty of it is it also allows you to in very detailed fashion, assess the shape of a symptomatic meniscus tear. Now, neither one of these tears is inciting inflammation. Neither one of these tears is associated with a cyst. Neither one of these tears is flipped, twisted, or displaced, or demonstrates instability. All reasons to be conservative in your description of this meniscus pathology, which is chronic. Shall we do another? These are nuanced things that are critical to the management and care of people. I'd much rather you be under-callers than over-callers. Save the whales, save the porpoises, save the menisci. This is a 16-year-old playing American football, a pretty tough game. Our professional football players weigh in at around 150 kilo. Many of them run the 100-meter in 11, 12 seconds, and they are amazing athletes. If they played European football, we might have a very good soccer or European football team. But they're all another sport, although admittedly that's beginning to change in the U.S. Soccer is becoming very big. Pardon? Hockey players, yes. Hockey players are tough. They are the toughest, especially the Russian ones. It's true, I watched one play with a dislocated, fractured elbow and score 2 goals. All right. I'm on my axial while you're scrolling. I'm noticing some signal in the distended capsule in the back. Perhaps that's a little bit of blood or synovium. I'm not sure. It's on both sides. I don't have any major patellar pathology. I have a nicely shaped patella. I have a nicely shaped trochlea. The reason I comment on this in every case is it's the most common cause of knee pain in people under the age of 20, patellofemoral disease, especially atraumatic. Now, I like my femoral end of my ACL. I'm not too keen on the mid portion, though. It's getting kind of gray and fading away. I like my PCL. I like my middle layer of my tibial collateral, but I don't like my superficial layer so much. It's a little gray and a little fat. I don't have a lot of swelling in the posterolateral corner. Here's my fibular collateral ligament here. Looks normal. Okay, so my primary area of interest is the anterior cruciate ligament. I still have not come up with a great explanation for why I have this tissue back here posteromedially and a little bit of blood here posterolaterally, but that will come. Now let's put up the rest of the study. You can see you can get through these pretty expediently. All right, bone pattern. Giving you about 30 seconds to reflect. There is a depressed femoral terminal sulcus fracture I didn't say microfracture. I didn't say contusion. I said fracture. It's depressed. Cortical break, fracture. Depression, fracture. These are microtrabecular components of the fracture. Spidery, contusive components, macrofracture, depression, undulation, but non-kissing. Remember our knee dislocation? Kissing. This time, pivot shift. A rotatory type of injury that occurs when the foot is planted in the ground with slight external rotation, often the patient being struck from the outside in. So there is a rotatory extension component to this injury. It's not a pure hyperextension injury. So once you see this, the chance of the ACL being intact is de minimis. You can put whatever percent you want on it, but it's less than 10%, probably close to 3%, and the ACL is gone. The PCL, swollen but present. How about the menisci? Let's start out on the easy side. Well, maybe not. Let's start out on the easy side. On this side, we have a double anterior lateral meniscus, but no posterolateral meniscus. As in our other case, we have sustained a folded, displaced bucket handle tear. So once again, we have something like this. With a big hole. The piece is kind of prolapsed forward. Now, sometimes this piece will go underneath in here. Sometimes it'll go over the front. You simply have to follow it. But the fact that we don't have a meniscus in the back and we have a meniscus in the front means we've got a bucket. And what does that mean? That means we want to go to surgery now, this week, so that our bucket can be repaired before it shrivels up into a ball. If we just had the ACL, we would absolutely want to wait for the swelling to subside to prevent the patient from having a stiff knee. So it makes a huge difference identifying the bucket. If we had a simple meniscus oblique tear, we would wait. But with a bucket handle tear, we have to sew it back together. So we want to do surgery within 7 days. It matters. Now, I alluded to the fact that the medial side was easier. It's not. We talked a little bit about the break-stop mechanism of the posterior medial corner, which basically prevents the meniscus from flopping back, especially in knee flexion. If the meniscus flops back in knee flexion, it gets pinched, and eventually it will rupture or tear or displace. And you'll get the meniscus doing this, flopping forward. And this patient has a problem. This time, we don't have a very good posterior medial corner. Look at the meniscocapsular attachment. It's ill-defined. This is known as the capsular component of the posterior medial corner. Here is the pars reflexa of the semimembranosus. Here's the direct head of the semimembranosus, inserting on the posterior aspect of the tibial tubercle. It has a specific name. I think it's called the semitendinous tubercle. And then we can see actually some of the more distal aspects of the semimembranosus, which occasionally can be confused with the pes anseri. So we have a posteromedial capsular corner injury or tear, a meniscocapsular separation of sorts. You can see how the meniscus is prolapsing posteriorly. So this may have to be dealt with and sewn. Now let's move over towards the capsule. Remember we said the posteromedial corner has a posterior capsular component to the meniscus and an oblique popliteal component. How's our oblique popliteal component looking? Not so good. Right there. It should be a nice, firm, straight or curvilinear arc-shaped black structure. It's not. In fact, it's torn right there. And we're on the posteromedial side. And look at this portion of the semimembranosus insertion. This is the anterior tibial arm right here, and it is swollen with a slight depression from the fracture. It gets rather complicated in the posteromedial corner, the oft-neglected portion of the knee. Overcall, you say? Look how swollen that is. Look at how the meniscus is prolapsing posteriorly. Imagine what happens when the patient flexes their knee. The meniscus is going to get pushed back and stuck between the femoral condyle and the tibia, which is now slightly deformed. So we have a posterocapsular corner injury, a small avulsion flake fracture with our semimembranosus corner injury, a depressed fracture of the terminal sulcus, a posterolateral tibial microtrabecular fracture, subcortical, an ACL transection. Let's check out our MCL. We said we thought the superficial bundle was swollen in the axial. We were right. It is. Here it is right here. Let's blow it up. It should be about 1 millimeter in thickness. It's too gray. There it is, too white. The tibial collateral, pretty good. The meniscofemoral attachment, pretty good. The meniscotibial attachment, excellent. Let's go back a little bit. This is called the POL right here, the posterior oblique ligament, part of the posteromedial corner. This little thing right here, it's intact. A little fluid underneath it. A little bone swelling underneath it. And then our bucket handle tear. Let's go to the back of the knee. Meniscus missing. And there is a piece and a very small rim, which should be described as a very small rim measuring no more than 2 to 3 millimeters in overall width. And there's our displaced, ripped bucket handle tear that is flopped forward, creating a double anterior meniscus sign. Earlier, you saw a double PCL sign with the medial meniscus piece slipping underneath the PCL on the opposite side. So this is a lateral bucket. So how would my conclusion read? Pivot shift injury, accompanied by A, ACL transection, B, multiple fractures involving the posteromedial corner and the anterolateral femoral terminal sulcus. C, low-grade MCL. Number next, effusion or hemarthrosis. Number next, posteromedial capsular corner separation and injury with meniscal prolapse posteriorly. Semimembranosus corner injury. End. Any other questions on this one? I probably would throw into the conclusion that the capsule is ruptured posteriorly, and that is why you have so much swelling in the back of the knee. All right, shall we move on? It's an 18-year-old female with right lateral knee pain since a rugby injury. Yes, there are women playing rugby. She had 2 injuries. One on October 12th and one on October 22nd. And so this study was done approximately 2 to 3 weeks after those injuries. Evaluate for anterior cruciate ligament tear. For goodness knows what reason, they did 2 axials. We have a PD fat suppression on the right, a T1 on the left. She's got an effusion. It's not uncommon with effusions, especially in girls and women who are rather robust or large, to see the patella in a lateral position. That is not an indicator of a patellar subluxation of acute nature. It's common. The reason for it is the medial vastus is underdeveloped compared to the lateral, vastus, and lateral structures, which contract and pull the patella over. Previously, we said we could look at our tibial collateral and the axial. It's fine. Do we have swelling in the posterolateral corner? We don't. Our posterior ligament, our oblique popliteal ligament is intact. Our popliteal fossa is normal. Our semimembranosus looks terrific. Looks great. There's no swelling there. Oh, maybe just a twinge. Got a lot of information so far, and we haven't even gone to any other sequence. Our ACL, not so good. Up high, fine, linear, black. Down low, not so much. It's gone. What about our PCL? PCL's still there. So far, we got a lot of information from just the axial. We're already suspicious that we have an ACL transection. So since it's the ACL that has tipped my hat, I'm going to the sagittal because I'm going to be expedient, efficient, and fast. Let's do it. The sagittal, ideal for the mid-ACL, although it does a pretty good job for the proximal femoral end. I like the axial better for it. Now, I think some of you might posit that the ACL is intact. There's no translation. The tibia is not forward. The effusion is not tremendous. And the ACL looks pretty straight, doesn't it? But if you really examine the fibers and you really window it down, right there, do they really look contiguous? And when you really examine these fibers, and you've seen some normal ACLs now, it should look like celery, right? Parallel. That's not parallel. That's not parallel. That's not contiguous. That's a piece of shredded, bitten celery. And then we go back to our axial for reaffirmation, quickly. And we have a bulbous ACL, not a straight, linear celery stick seen in cross-section. And then we can go to the coronal. And where is our ACL? It's terrible. I don't know why they got this sequence, a proton density. We don't use that very often, but the T1 shows a massively swollen ACL without any identifiable straight fibers as they're buried in blood. So you can call this a functional full-thickness ACL tear or just an ACL transection. Either one works. Are we done? Of course not. We've had a pivot shift injury of some kind. Let's take a look at our skeleton for a moment and see if there are any supportive signs of such. There is. There's at least one component of the pivot shift in the back. We did not sustain a femoral terminal sulcus injury, but supportive information for our ACL tear. How's our posterolateral corner looking? Quite good. We've got a nice, thick popliteofibular ligament. For when it tears, it'll roll up in a ball like this, and you'll get a little tail to it. It'll be transected off the fibula, and that's known as the mermaid sign. We've got a little swelling in the arcuate fossa. There's the arcuate. It's okay. It's normal. There are two limbs to the arcuate, which we'll show you in our next corner case. Let's keep going. How about our posterior capsule? We said it looked pretty good, and it does. I wouldn't say it's the best view of it sagittally. Maybe this one will show it a little better, the T2. It does. There's our arcuate capsule. Sorry. There's our posterior capsule. It's a mediocre look at it. We have not taken on the medial collateral ligament. It's a little swollen. I'd use the all-purpose grade here, grade 1 to 2, low grade. Little swelling of the tibial collateral, little swelling superficial to it. Nothing too terrible. I'd probably put it in the body. The lateral side, fine. The posterolateral corner, fine. That's going in the body. So what haven't we discussed yet? The menisci. Let's do that. Where would we expect to find meniscal tears in an ACL pivot shift injury? The root might be one place. Radial tears near the root. Vertical tears near the back. And occasionally flap tears in the posterior medial meniscus. So why do we get these tears in the back? Because we have this. The tibia goes forward, the femur goes back, and they impact and twist. So you put pressure down on the outer third of the posterior menisci. So it is common to see slits or tears in the meniscocapsular reflection. As long as there's not globular swelling and displacement like you saw earlier, no worries, it'll heal. So we might call that a meniscocapsular sprain. Or if it's inside in the meniscus vertically, we would call it either a full thickness, or in this case, partial thickness, vertical tear, and then we count slices. So it's here. It's at the posterior medial corner. So one slice, we'll call it 4 millimeters. 4, 8, 12, 16, 20. Also say it's about 2 centimeters, 2 to 2.5 centimeter vertical tear with slight complexity in the outer red healing zone of the posterior medial meniscus of the knee with meniscocapsular sprain. Translation, do no harm. Leave that meniscus alone. You can't take that out. You can put some sutures in it. We used to suture all of them when they were over 2 centimeters. Now, not so much. Now we just let them heal. How long will that signal persist? The signal will go down. It'll be less bright, but the actual signal will persist forever. So if somebody re-injures their knee and you see vertical signal in the back, to decide whether that signal is new or old, you have to look at its intensity, because this will fade to gray but still persist throughout life as a scar in the meniscus, but still be stable. And that's contrary to what was taught 15 or 20 years ago. All right, so we have a meniscus tear. It is a vertical tear with slight complexity, 2 to 2.5 centimeters in length, posterior horn to body. That would be number 2. Number 1, ACL transection, likely pivot shift mechanism of injury with moderate size effusion, 2 out of 4. Menisci otherwise spared. And then while you're looking at a case like this in the body, you should examine the meniscotibial attachments, which are intact. That would not go in the conclusion.